The Healthcare Labyrinth podcast is back for another episode. Join Mark S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth podcast. My name's Mark Ryan, and it's a pleasure to be hosting the podcast. And thanks to everyone for listening in. We are going to stay on our Medicare Advantage topic this week and get into some real granular level detail related to a recent Medicare Advantage in Part D 2026 rule issued by CMS. Now, I did have an earlier general podcast on this relating to all the sweeping changes within it. But I did want to come back on this podcast and talk specifically about the medical loss ratio rule changes that were being proposed by the Centers for Medicare and Medicaid Services. I characterized this in the podcast I did about the rule in general as one of the controversial areas of the rule. So I wanted to come back and tell you a little bit more about it. In general, I'm supportive of the MLR rule, and I'm even supportive of some changes to them as CMS is talking about. But I think we have to be very, very cautious about what we're doing. So that's the real purpose of this podcast today, to urge CMS to be very level-headed on the medical loss ratio rule changes they're proposing in the 2026 MA and Part D rule. So let's get right into it. We'll take our normal breaks along the way, our 3 breaks, but let's start to digest a little bit about what this medical loss ratio changes are. So in a parting shot at the private managed care industry, the Biden administration's Centers for Medicare and Medicaid Services issued again a 2026 Medicare Advantage and Part D proposed rule for 2026 that would make major changes to the minimum medical loss ratio requirements in the Medicare managed care program. This comes as Capitol Hill is shining a light on a number of MA program issues, including overpayments, risk adjustment abuses, supplemental benefits, marketing, poor star performance, and the vertical integration of top national health insurers. These top national players control about 3/4 of all MA enrollment right now. So let's talk a little bit about what we mean about the medical loss ratio and, more importantly, what I'm going to define as the minimum medical loss ratio here. So most lines of businesses now have MLR requirements. That's the medical loss ratio requirements, except self-funded employer plans. In these cases, businesses are at risk for healthcare expenditures as opposed to insurers. So the MLRs don't apply to those self-funded employer plans. Insurers will still administer such self-insured plans, usually for a set administrative fee. The rules, the MLR rules across various lines of business require at-risk health plans to report how much of the premium it receives is spent on medical expenses. The percentage of medical expenses against total premium is known as the medical loss ratio. The rules were put in place to ensure that margins for insurers are not excessive, as well as to control the growth of premiums year to year. The calculation of the medical loss ratio is based primarily on the National Association of Insurance Commissioners, or NAIC, MLR policies, with some tweaks by various state and federal regulators. Generally, plans must spend at least 85% of premium on medical expenses in Medicare Advantage and in most states for Medicaid, although some states have higher requirements. In the at-risk large group market, those that aren't self-insured, the requirement is also 85% of premium being spent on medical expense. In the small group and individual markets, the requirement is 80%. So in essence, again, the MLR rule was put in place, and if you don't hit those minimums across these broad categories, if you're a health plan, small group, individual together, large group at risk, Medicare Advantage and Medicaid, you pay back a portion of that revenue back to either beneficiaries, meaning in the individual market, or in the case of government programs to the government regulator, or in the case of small group and large group at risk, it would go to the employer. So with that explanation about the medical loss ratio requirement and what a minimum MLR is, we'll take our first break and we will come back to go into what the 26 MA rule does on the medical loss ratio front. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Mark Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Mark dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Mark is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Mark's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We are talking about the recent 2026 MA and Part D rules proposals on medical loss ratio changes. So as I promised, we were going to talk about what does the 2026 MA rule do on the MLR issue. CMS says the MLR regulations will be changed to improve the meaningfulness and comparability of the MLR across plan contracts. The rule does the following. The changes will help align the requirements to commercial and Medicaid current requirements in MA. Administrative costs will be excluded from being included in quality improvement activities in both the MA and Part D MLR numerator. Next, the rule would adopt additional requirements for the allocation of expenses in the MLR. And finally, new audit and appeals processes are introduced under the rule. Now, the big controversial proposals, however, are the following. Number one, the rule would require that provider incentive and bonus arrangements are tied to clinical or quality improvement standards in order to be included in the minimum MLR numerator calculation. Number two, the rule would also require plans to provide detailed information regarding provider payment arrangements. And third, CMS is also seeking information on potential policies that CMS could adopt regarding how the MA and Part D MLRs are calculated in order to enable policymakers to address concerns surrounding vertical integration in MA and Part D. So what is the current concern that are really having CMS make these more controversial proposals? Well, there is growing concern that health plans essentially are getting around the minimum MLR by downstreaming revenue to providers and perhaps subcontracted vendors and essentially booking revenue as medical expense when it may not be. The concern can be divided into two areas, one far more important than the other. First, when plans contract with providers or other subcontracted entities that are not owned by the plan, there is some concern that overly generous arrangements that downstream revenue to entities that take on risk may mean dollars going to profit rather than true medical expense. These arrangements can be divided into two categories with additional subcategories. They can include providers taking on full or partial risk on both the up and or downsides. By their nature, then, it would seem clear that not all the revenue downstreamed is truly going to medical expense. Providers have to be incentivized to save money. Oftentimes, but not always, quality outcomes are part of the arrangements too. Why would a plan offer an overly generous deal to an independent physician group? Because the doc group in turn could funnel all its members to the plan, which drives incremental margin for the plan. The second issue, which is more worrisome, are what are known as intra-company deals between health plans and sister entities within a larger global healthcare entity. As examples, think here about United Healthcare and Optum, Aetna and CVS Caremark, Cigna and Evernorth, and Elevance Health and Carelon. These arrangements can take on many forms. Health plans contracting with sister pharmacy benefit managers to administer the drug benefit. Health plans contracting with sister retail, mail order, or specialty pharmacies either directly or through the related PBM. Health plans contracting with sister medical management or services entities. These could carry out various utilization, care, or quality management functions. And health plans contracting with sister, wholly owned or partially owned provider groups. These contracts would be along the lines of the global and partial risk arrangements I noted just earlier. Now, not every service between a plan and a sister company qualifies within the MLR calculations. But what worries regulators and lawmakers is that many speculate, and there is some evidence of such already out there, that these intra-party contracts exceed market rates and are still booked as medical expense. Again, a few examples. Health plans give their sister PBMs overly generous reimbursement for drugs and other services. Health plans give their various sister pharmacies excessive reimbursement for drugs. Health plans give their sister medical management or services entities excess reimbursement via risk arrangements. Pure admin costs would not be within the MLR. And last, health plans give sister provider groups global and partial cap deals that are excessive. So with that explanation about the concerns right now that CMS and Capitol Hill lawmakers have, we'll take our second break and go a little deeper into the MLR rule changes, as well as could the MLR changes be excessive and hurt the emerging value-based paradigm. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking about the proposed 2026 MA and Part D rules, medical loss ratio changes that are proposed, and some of the complexity of them and how it could lead to bad outcomes if CMS is not particularly level-headed in implementing the rule. So, again, let's get a little more into the MLR rule changes a little bit further explained here. So with regard to the proposed, CMS believes a good test for whether provider downstream revenue should be calculated in MLRs is if the provider incentive and bonus arrangements are tied to clinical or quality improvement standards. Specifically, CMS says only those provider incentives and bonuses made or expected to be made that are tied to clearly defined, objectively measurable, and well-documented clinical or quality standards that apply to providers may be included in incurred claims in the numerator for the MLR calculation. CMS says this would align such bonus payments with care outcomes and avoid excess premium transfer to providers. In addition, CMS would ensure plans supply detailed information related to the provider payment arrangements. Today, these arrangements are confidential between the plans and providers. With the information, CMS would be able to assess the contracts. In asking for information regarding concerns surrounding vertical integration in MA and Part D, CMS is really attempting to go even deeper to address the intra-company deals that the highly vertically integrated healthcare companies have. CMS is concerned that while health plan margins may be about 5% on average, PBM and medical service entities seem to have margins that are double or triple the insurance margins. Is this driven by inappropriate downstreaming of MA revenue? That's sort of the question that CMS is asking. So could the MLR changes be excessive and hurt the emerging value-based paradigm? Well, let me take it in two different ways. On the whole, I understand what CMS is doing here. I feel that the minimum MLR rule is a good one. It ensures more premium revenue going to medical expense. It provides for a disincentive to have excessive prior authorization and claims denial approaches, and it helps limit premium hikes. I also feel that the minimum MLR has to have integrity. Using NAIC's approach is an important first step, but stopping inappropriate shifting of revenue within a large healthcare organization to get around the MLR rule is also very important. And I think that's what CMS is trying to do here. At the same time, caution is clearly needed. If CMS were to adopt overly stringent definitions related to provider payments or overly restrict intra-party agreements, it could stymie reform and potentially even drive up costs. And when we get back from our third break, I'll give you two very important suggestions that I think CMS should take into consideration when really adopting the final rule. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Mark Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Mark's insights. Twice a week, Mark publishes a blog to go deep into a current issue. And of course, Mark hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Mark's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking about the MA and Part D proposed 26 rules, medical loss ratio changes that are proposed. So I told you that I'm a little bit worried that CMS could go a little bit too far in their proposal, but that at base I do support the MLR rule in some of the changes CMS is making. So here are my two suggestions to CMS when they adopt the final rule. First, CMS should ensure that provider agreements include ties to clinical and quality standards. So I support the concept. It should, though, resist putting limits or caps on what these doctor groups can earn if they do deliver cost savings and drive quality. That would impact the emerging value-based care arrangements throughout the nation between plans and providers. Here is a different way of looking at it. A Medicare fee-for-service doctor theoretically earns margin within each payment for a service. The problem is the doctor is incentivized in the fee-for-service system to provide as many services as possible to drive more and more income and margin. This drives unnecessary utilization and costs. So there is nothing wrong with a provider reducing trend in MA and increasing quality and profiting from it. Number two, like CMS and Capitol Hill, I too am worried about intra-party agreements and whether they are excessive. So again, I support the spirit of what's being talked about. In the end, inappropriate contracts drive costs to the system and to consumers at the point of service. It also could encourage more and more consolidation, which impacts costs as well. As such, CMS should collect sufficient information on all provider and intra-company deals to ensure that agreements constitute arm's-length transactions and meet market rate conditions. So what is an arm's-length transaction? Well, in business, an arm's-length transaction occurs when two parties are independent and unaffiliated. They act in their own self-interest, have roughly equal bargaining power, and access to the same information. By including an arm's-length standard in the final rule, intra-party agreements would then be as cost-effective and efficient as true arm's-length agreements in the industry. It would allow intra-company agreements to continue to move forward, but not have that bias of passing on too much to sister companies and getting around the medical loss ratio requirement. Before we conclude the podcast, I just wanted to comment on one last thing related to administrative costs for quality improvement. As I talked about earlier, CMS wants to remove the ability to include administrative costs for quality improvement activities in the MLR numerator. I wonder if CMS is being penny-wise and pound-foolish if it excludes administrative costs from being included in quality improvement activities in the MA and Part D MLR numerator. By any definition, this is what we call good admin spend at a health plan. Will something like this, as proposed by CMS, serve as a disincentive for plans to hire qualified clinicians and invest in administratively heavy initiatives? It quite possibly could. So I think CMS needs to revise what they're proposing here as well. With that, we will conclude this episode of Healthcare Labyrinth Podcast, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.